Thank you, June, for that kind and generous introduction, and my mother thanks you also. I do want to thank you, June, and Dr. Chappell for your kind invitation for me to speak to you tonight. In her letter of invitation, June asked me to address a specific topic in the area of anesthesiology, where my contributions have been significant and are widely known. I have struggled with that assignment, in part because I do not want to give a self-congratulatory presentation. Initially, I thought that I might provide an overview of my research, but I concluded that such a presentation would be too narrow. Therefore, I have decided to share with you several snippets from my career. I will begin by describing a humbling start. I will then discuss some of my clinical research, and I will relate that research to controversies in the practice of obstetrics. Then I will discuss two situations in which I have been involved with decisions regarding public policy. And finally, I will conclude with a brief discussion of the opportunities for Christian academic physicians to be salt and light in a secular academic medicine environment. I acknowledge that some portions of my presentation are somewhat technical, and hopefully you received a glossary that might be helpful. Let's begin with prayer, a prayer written by John Calvin. Heavenly Father, in your Son Jesus Christ are hidden all the treasures of wisdom and knowledge. Enlighten our minds by your Holy Spirit, and grant us that reverence and humility without which no one can understand your truth. Through the same Jesus Christ, your Son, our Lord. Amen. In January 1989, after completing my anesthesiology residency training at Duke University Medical Center, I began my obstetrics and gynecology residency also at Duke. As I began that second residency, I had a high level of personal confidence. I thought, how fortunate they are to have me as a resident in this program. After all, I am not like all the other residents who have come straight from medical school. I have already completed a full anesthesiology residency, and I have a lot to offer this program. One day, after I had been in the program for 3 weeks, my chief resident grabbed me, pulled me into the resident call room, and slammed the door. As he threw me to the bed, he said, "Chestnut, sit down." He then said, "I don't know how to tell you this, but I have to tell you. The obstetric nurses hate your guts. And if you do not change, you will not survive this residency program. In fact, you may not survive your first rotation." Well, I am happy to tell you that I changed. From that day forward, I started using the words please and thank you more often. When it was time for me to make a clinical decision, Jim, I would first ask the nurses for advice. Several years ago, the obstetrician Patrick Duff wrote an excellent essay on professionalism in medicine. He concluded, correctly I think, that humility should be at the top of the list of desirable professional attributes. Dr. Duff acknowledged that obstetric nurses typically offer the harshest critiques of both resident and faculty physicians, and obstetric nurses can be especially hard on young anesthesiology residents. Nonetheless, I have learned that respect is not an entitlement. Self-awareness and humility are virtues, even for physicians. In my experience as a department chair and residency program director, I have concluded that the way that a junior resident responds to criticism is the single best predictor of future success. I have also learned that good relationships with the nurses and staff are critically important. I have observed that recurrent conflict between an anesthesiology resident and an obstetric nurse is a predictor of future trouble. For that reason, I never tried to hire one of my residents who could not learn to get along with the obstetric nurses. I should add that self-awareness is not always sufficient. Once I was counseling a resident physician who was having difficulty getting along with the nursing staff. She said, "I am at a disadvantage in this training program because all of the other female residents are nice and sweet, and I am not sweet." Well, after a rocky start, I successfully completed my residency in obstetrics and gynecology, and I decided that it was time to start looking for a real job. I wanted a position that would allow me to practice both anesthesiology and obstetrics and gynecology, and it became clear that I could achieve that goal only in an academic environment. This caused me some anxiety because I had little research experience. During my interview, I voiced that anxiety to Dr. Frank Zlotnick, a faculty obstetrician at the University of Iowa. He asked me, "Do you know how to ask good questions?" Good research results from asking the right questions. In July 1984, I began my work at the University of Iowa College of Medicine. 3 or 4 months later, we hosted a prominent obstetric anesthesiologist as a visiting professor. I asked him, "Do you think that we need to perform a randomized clinical trial of epidural analgesia versus systemic opioid analgesia in laboring women?" He looked astonished, and he firmly replied, "No." To this day, I regret the fact that I accepted his advice. In 1984, the epidural analgesia service at the University of Iowa was in its infancy. We had an excellent opportunity to perform a randomized clinical trial of epidural analgesia versus systemic opioid analgesia in laboring women. And we missed an opportunity to answer some important clinical questions regarding the risks and benefits of epidural analgesia during labor. Students, I would remind you of the words of the Apostle Paul. "Do not let anyone despise you for your youth." As you go through your training, you will ask, "Why do we do it this way?" Do not accept the answer, "Because we have always done it that way." Ask questions. Challenge medical dogma. Discover new knowledge. During the next 6 years, we did perform 4 randomized clinical trials in which we addressed the controversy regarding the management of epidural analgesia during the second stage of labor. In brief, we concluded that maintenance of total epidural anesthesia until delivery likely prolongs the second stage of labor and results in more instrumental vaginal deliveries. Second, anesthesia-related prolongation of the second stage of labor does not worsen newborn oxygenation and acid-base status at delivery. Third, the addition of an opioid to a dilute solution of local anesthetic results in a decreased total dose of local anesthetic and less intense maternal motor block. Such a regimen seems to allow provision of reasonable pain relief, but not total anesthesia, without increasing the likelihood of instrumental vaginal delivery. But meanwhile, a new controversy erupted, which caused me to regret the missed opportunity I mentioned a moment ago. In 1991, Thorpe reported results of a retrospective study of 500 nulliparous women at term gestation. The incidence of cesarean delivery for dystocia was 16% in women who had received epidural analgesia versus 2% in women who had not. Further, the apparent adverse effect of epidural analgesia on the incidence of cesarean delivery for dystocia was greater in women who received epidural analgesia at or before 5 centimeters cervical dilation. The study was seriously flawed. Retrospective studies suffer from selection bias. For example, women who have an abnormal, prolonged labor are more likely to request and receive epidural analgesia than women who have a rapid, uncomplicated labor. Also, the greater labor pain intensity experienced by women who request epidural analgesia may be a marker of increased risk for operative delivery. Nonetheless, this study had high impact, and some third-party payers cited this and other studies as a rationale for imposing restrictions on the administration of epidural analgesia during labor. In 1991, independent physicians of San Antonio stated that epidural anesthesia is only considered a covered benefit if documentation of an approved medical indication is provided with the claim. Labor epidural analgesia provided solely for the patient's comfort or upon request by the patient is not a medical indication. In response, in 1992, the American Society of Anesthesiologists and the American College of Obstetricians and Gynecologists published a joint statement on pain relief during labor. At that time, I was the official liaison from the ASA to the ACOG, and I was the primary author of this joint statement. We acknowledged that some third-party payers have denied reimbursement for epidural analgesia during labor unless a physician has documented the presence of a medical indication for epidural analgesia. We wrote that labor results in severe pain for many women. There is no other circumstance where it is considered acceptable for a person to experience untreated, severe pain, amenable to safe intervention while under a physician's care, and that maternal request is a sufficient indication for pain relief during labor. Meanwhile, prospective randomized trials were performed. To my knowledge, no one has performed a study in which patients were randomly assigned to receive epidural analgesia or nothing. Rather, prospective randomized trials have typically compared epidural analgesia versus systemic opioid analgesia. These studies were possible and were considered ethical by institutional review boards because the obvious benefit of more effective analgesia was offset by the perceived increase in the risk of operative delivery. The group at Parkland Hospital in Dallas, Texas, published a series of 5 prospective randomized trials of epidural versus intravenous meperidine analgesia in laboring women. An analysis of those trials demonstrated no difference between the epidural and intravenous meperidine groups in the incidence of cesarean delivery. However, the incidence of instrumental vaginal delivery was 13% in the epidural group versus 7% in the intravenous meperidine group. A 2010 Cochrane review, which included data from 21 studies involving over 6,000 women, concluded that epidural analgesia had no significant impact on the cesarean delivery rate, but that women who received epidural analgesia were at increased risk of having an instrumental vaginal delivery. Altogether, these prospective randomized trials refuted the suggestion that epidural analgesia increases the risk of cesarean delivery, although they provide further evidence of an association between epidural analgesia and instrumental vaginal delivery. But another controversy surfaced, namely, does the timing of the initiation of epidural analgesia make a difference in obstetric outcome? When asked, when is it too early or too late to begin epidural analgesia, my colleague David Birnbach replied, "It is too early to give epidural analgesia before conception, and it is too late after the patient has been discharged from the hospital." The American College of Obstetricians and Gynecologists issued these guidelines. When feasible, obstetricians should delay the administration of epidural analgesia in nulliparous women until the cervical dilation reaches 5 centimeters, and other forms of analgesia should be used until that time. Likewise, third-party payers issued similar recommendations. For example, in 1996, United Healthcare issued guidelines stating that administration of epidural analgesia should be delayed until 5 centimeters cervical dilation to reduce the risk of cesarean delivery. But many women experience severe pain and request pain relief before 5 centimeters cervical dilation. At the University of Iowa, we performed 2 studies that assessed the timing of the administration of epidural analgesia on the incidence of cesarean delivery. Nulliparous women in spontaneous labor at term gestation who requested analgesia, epidural analgesia, between 3 and 5 centimeters cervical dilation were randomly assigned to receive either epidural analgesia at the time of their request or to receive intravenous nalbuphine followed by administration of epidural analgesia when the cervix was 5 or more centimeters dilated. There was no difference between the 2 groups in the incidence of cesarean delivery. Further, early administration of epidural analgesia did not prolong labor when compared with intravenous nalbuphine followed by late administration of epidural analgesia. As expected, women in the early epidural group had much less pain during the first 150 minutes after they were randomly assigned to receive either early or late epidural analgesia. Of interest, infants in the early epidural group had more favorable umbilical cord blood gas and acid-base measurements at delivery, probably because women in the late group experienced some respiratory depression as a result of receiving the intravenous nalbuphine. We performed a similar study of nulliparous women who were receiving intravenous oxytocin for induction or augmentation of labor at the time of request for epidural analgesia. Early epidural analgesia did not prolong labor or increase the incidence of cesarean delivery. And subsequently, our results were confirmed in similar studies performed at Northwestern University and Zhou in China. Altogether, these studies allowed us to make the following conclusions. First, the presence of severe pain during early labor may signal a higher risk for prolonged labor and operative delivery. Second, epidural analgesia does not result in a higher cesarean delivery rate than does intravenous opioid analgesia. And third, initiation of epidural analgesia in early labor does not prolong the duration of labor or increase the cesarean delivery rate when compared with the use of intravenous opioid analgesia. In 2006, the ACOG revised their guidelines and stated, "The fear of unnecessary cesarean delivery should not influence the method of pain relief that women choose during labor." But meanwhile, the cesarean delivery rate in the United States continues to climb. It now exceeds 32%. 1 in 3 babies born in the United States are now delivered by cesarean. I have long argued that other factors are responsible for the increased cesarean delivery rate. Obstetric management and demographic factors include the almost universal use of continuous electronic fetal heart rate monitoring, the abandonment of vaginal breech delivery, the increased prevalence of maternal obesity, the increased weight of newborn infants, the fear of litigation, the decreased popularity of vaginal birth after previous cesarean, and the increased incidence of elective induction of labor. A recent study reviewed records for over 228,000 deliveries at 19 hospitals in the United States between 2002 and 2008. 44% of women who attempted vaginal delivery underwent induction of labor. The cesarean delivery rate was twice as high in women who underwent induction of labor than in women who had a spontaneous onset of labor. Obstetrician Roger Freeman recently stated, "The single most positive thing you can do to prevent primary cesarean delivery is to avoid elective induction of labor." And finally, we are now witnessing an increase in the number of cesarean deliveries performed for maternal request without any obstetric indication. In 2006, an NIH panel concluded that cesarean delivery on maternal request may be a reasonable alternative to planned vaginal delivery. However, the panel emphasized that cesarean delivery on maternal request should not be motivated by unavailability of effective pain management, and efforts must be made to assure availability of pain management services for all women. In 1997, I wrote that maternal fetal factors and obstetric management, not the use of epidural analgesia, are the most important determinants of the cesarean delivery rate. That conclusion remains true today. Consider the irony. 2 decades ago, obstetricians feared that the early administration of epidural analgesia might increase the risk of cesarean delivery for dystocia. Today, the availability and even the early administration of epidural analgesia may dissuade women from choosing to undergo an unnecessary cesarean delivery. I now want to share a few details of 2 situations in which I was involved in public policy decisions. In 1995, Congress held hearings on a bill to ban partial birth abortions. Proponents of this gruesome procedure dismissed the concerns that the procedure is painful for the baby by claiming that anesthesia given to the mother causes intrauterine fetal death prior to the abortion. One physician testified before Congress that the fetus dies of an overdose of anesthesia given to the mother intravenously. and that this induces fetal brain death in a matter of minutes. This, of course, was and is a preposterous lie. Besides the fact that partial birth abortion involves the destruction of a human life, this false testimony misrepresented the potential for fetal pain, and also it had negative implications for pregnant women who receive anesthesia for surgery during pregnancy, as well as for pregnant women who receive anesthesia for labor and vaginal or cesarean delivery. Nonetheless, writers for USA Today and the St. Louis Post-Dispatch cited this false testimony in published editorials written in opposition to the proposed legislation. In March 1996, I was invited to testify before the United States House of Representatives Judiciary Committee in a hearing on the effects of anesthesia during a partial birth abortion. In my opening statement, I called attention to both the necessity and safety of anesthesia for surgery during pregnancy. As many as 75,000 pregnant women receive anesthesia for non-obstetric surgery during pregnancy each year in the United States. Examples of commonly performed surgical procedures during pregnancy include appendectomy, cholecystectomy, and removal of malignant tumors. In many cases, postponement of surgery until the completion of pregnancy would compromise the mother's health. I stated that the vast majority of women who undergo anesthesia for surgery during pregnancy subsequently deliver a healthy baby. I emphasized that the testimony that maternal anesthesia causes fetal death was nonsense, but I expressed concern that the false testimony might cause some pregnant women to delay necessary and even life-saving surgery during pregnancy, and it might prompt other women to deny themselves adequate pain relief during labor and vaginal or cesarean delivery. I then called attention to the small doses of anesthetic drugs given to provide maternal sedation during partial birth abortion. And I testified, clearly those doses would not result in fetal death, and it is unlikely that those doses would result in substantial fetal sedation or analgesia. 2 years earlier, in 1994, I had published the first edition of my textbook, Obstetric Anesthesia, Principles and Practice. In my textbook, we outlined the rationale for giving analgesic drugs directly to the unborn child during performance of intrauterine fetal surgery. Although anesthetic drugs given to the mother cross the placenta to the fetus, transplacental transfer of anesthetic drugs does not ensure provision of fetal anesthesia or analgesia. Despite the administration of general anesthesia to the mother, fetal surgeons give additional analgesic drugs directly to the fetus at surgery in order to decrease the likelihood of fetal pain during surgery. The next 2 hours of the congressional hearing can only be described as a spectacle. The first question from Congresswoman Patricia Schroeder had nothing to do with the scientific basis of my testimony. Rather, she asked, "Do you support Roe versus Wade?" The next day's Washington Times reported that a congressional hearing on the effects of anesthesia on partial birth abortion turned into a shouting match between Representative Patricia Schroeder and other subcommittee members. Fast forward to the publication of the fourth edition of my textbook in 2009. The discussion of fetal nociception, that is, fetal perception and awareness of physical pain, was co-authored by Dr. Andrew Harris, professor of anesthesiology at Johns Hopkins and who now serves in the United States House of Representatives. Current evidence suggests that fetal nociception at the level of the cortex occurs after the midpoint of pregnancy, perhaps as early as 24 to 26 weeks gestation. Maternal administration of general anesthesia does not guarantee the presence of fetal anesthesia or analgesia. For example, most infants are clearly awake and cry loudly immediately after cesarean delivery during maternal administration of general anesthesia. The following year, Congress approved legislation outlawing partial birth abortion, but this legislation was vetoed by President Clinton. Similar legislation was again approved by Congress in 2003, and in 2007, its constitutionality was upheld by the Supreme Court. A second opportunity for me to be involved at the intersection of anesthesiology and public policy relates to the subject of government-sanctioned execution by lethal injection. The execution by lethal injection protocol was devised and described by an anesthesiologist in 1977. Until recently, the protocol typically involved the sequential injection of a large dose of a barbiturate, such as sodium thiopental, to provide hypnosis or sleep, a paralytic agent such as pancuronium to stop all respiratory activity, and a large dose of potassium chloride to stop the heart. This protocol was first used for execution in 1982, and lethal injection is now used by all states with the death penalty. The public debate over the use of medicine to perform execution began early. In 2002, this author wrote that by adopting lethal injection for executions, the law turned to medicine to rescue the death penalty. The potential for physician involvement in lethal injection became quickly apparent. Early opposition was voiced by the American Medical Association. These authors noted that lethal injection represents a direct threat to medical professionalism because it requires the direct application of biomedical knowledge and skills in a corruption and exploitation of the healing profession's role in society. Nonetheless, in 2001, Farber noted that as many as 41% of physicians stated that they would agree to participate in executions. Dr. Atul Gawande interviewed several physicians who have participated in executions, and he wrote about those conversations in a thoughtful but sobering commentary published in New England Journal of Medicine. Why would states ask physicians to be involved in execution by lethal injection? In brief, not just anyone can do it. It is often difficult to obtain intravenous access in the condemned, many of whom have abused drugs intravenously. Even preparation and administration of the drugs is complicated. For example, if thiopental comes in contact with the pancuronium, the two drugs turn to concrete. Through the years, reports of botched executions have included claims of multiple unsuccessful attempts at intravenous access, postponed executions with the condemned sent back to his cell with a plan to return another day, and claims that some condemned individuals were paralyzed without first being unconscious and thereby subjected to a protracted death by suffocation. As a result, in recent years, federal courts have issued orders requiring the participation of an anesthesiologist in the lethal injection. In 2006, the American Society of Anesthesiologists stated that execution by lethal injection has resulted in the incorrect association of capital punishment with the practice of medicine, particularly anesthesiology. Although lethal injection mimics certain technical aspects of the practice of anesthesia, capital punishment in any form is not the practice of medicine. Because of ancient and modern principles of medical ethics, legal execution should not necessitate participation by an anesthesiologist or any other physician. And ASA strongly discourages participation by anesthesiologists in executions. Unfortunately, it became clear that these and other statements from professional societies did not represent a sufficient deterrent to physician participation in lethal injection, as these voluntary professional societies have limited ability to enforce ethical guidelines. For the last 14 years, I have had a leadership position with the American Board of Anesthesiology. Between 2006 and 2010, the ABA engaged in debate as to whether we should address this issue. In 2010, we added the following statement to the ABA professional standing policy. An anesthesiologist should not participate in an execution by lethal injection. Violation of this policy is inconsistent with the professional standing criteria required for ABA certification and maintenance of certification or any of its subspecialties. ABA certificates may be revoked if the ABA determines that a diplomate participates in an execution by lethal injection. The response has not been uniformly positive. Criticism has varied depending on the source of the criticism. For example, some physicians have expressed concern that the ABA might prohibit an anesthesiologist's administration of anesthesia for abortion. And others have suggested that by singling out lethal injection, the ABA has implied endorsement of abortion or euthanasia, which clearly is not the case. I believe that both abortion and euthanasia are a violation of the physician's obligation to protect human life and to do no harm. But with the exception of the Christian Medical Association, no major professional society or certifying board will reach consensus on that perspective. I should emphasize that the ABA did not take a stand for or against the morality of capital punishment. But the ABA policy represents a strong endorsement of historic physician professionalism, of which I am proud. As an aside, 2 months ago, the pharmaceutical company Hospira, with headquarters in Lake Forest, Illinois, announced that it will exit the sodium thiopental market and cease production of its product pentothal because it could not prevent the use of the drug for government-sanctioned executions by lethal injection. The Italian Parliament had demanded that Hospira guarantee that none of its made-in-Italy thiopental would be used for lethal injection. Hospira could not make that guarantee and decided to cease production. The front-page story in the Wall Street Journal said that the decision would likely cause a substantial delay in executions across the country. The journal made no mention of the impact of this decision on medical care. Admittedly, the anesthetic drug propofol has mostly, but not entirely, replaced thiopentol for induction of general anesthesia in the United States. The World Health Organization continues to list thiopentol as an essential medicine for any healthcare system. For example, sodium thiopentol's unique properties sometimes make it especially useful in treating patients with severe brain injuries. Physicians may use thiopentol to induce a pharmacologic coma, to reduce cerebral oxygen consumption, and increase the likelihood of neurologic recovery. The American Society of Anesthesiologists correctly noted that, ironically, many more lives will be lost or put in jeopardy as a result of not having thiopentol available for legitimate medical use. I will conclude by briefly discussing the opportunity and challenge for Christian physicians to be salt and light in the secular academic medicine environment. I could provide a long list of my failures in this regard. I will give you one specific example. In 1994, I was named chair of the Department of Anesthesiology at the University of Alabama at Birmingham School of Medicine. Shortly thereafter, Janet and I hosted a dinner for 200 resident and faculty physicians and their spouses. Before dinner, I offered a general, non-specific prayer, and it was a bomb. I once thought that such a prayer offends no one. I have learned that such a prayer offends almost everyone. I have also concluded that a vague, non-specific public prayer to a non-specific deity is not an effective Christian witness, and it borders on polytheistic paganism. Today, when hosting a social event in a secular environment, I may allow time for a moment of silent reflection, but I will not pray out loud unless I am prepared to pray in the name of Jesus Christ, our Lord. How does a Christian in any position of leadership demonstrate a faithful presence? If I could offer only one suggestion, I would call attention to the exhortation of James. Let your yes be yes, and let your no be no. Character and integrity matter. Sadly, leaders of certification boards and medical educators all agree that there is a crisis of professionalism in medicine today. For example, perhaps the most vexing issue facing the physician certification boards today relates to problems with examination security and the prevention and detection of cheating on physician certification examinations. This is the cover for this month's issue of Anesthesia and Analgesia, which features several sobering articles and editorials on academic misconduct. Why do we have a crisis of professionalism in medicine? I think these authors have correctly identified the problem. They wrote, "The emperor of medical professionalism, as described in the various statements on professionalism, has no clothes. There is no common consensus or morality intrinsic to modern medical practice in which the professional virtues can be firmly cultivated and grounded." Their essay exposes the difficulty of establishing a code of professionalism within medicine without a moral community other than medicine as the foundation for such codes. The authors recommended that medical students should be encouraged to participate in communities of virtue that will allow the professional virtues to be cultivated from within rather than imposed arbitrarily from without. This essay reminds us that medicine has no solid ethics without God as its foundation, and it lays the groundwork for the argument that the gospel and the Christian community are essential aspects of a medical student's professional development. Of course, that is not the prevailing view. Students, be prepared for opposition, perhaps even sacrifice, even persecution, as you live your Christian faith in the workplace. You have grown up in a time of public recognition and material prosperity for the American evangelical Christian community. But that landscape is rapidly changing. Several years ago, Michael Lindsay wrote the book, Faith in the Halls of Power: How Evangelicals Joined the American Elite. One day he may write the sequel, Evangelicals Outside the Halls of Power. A serious Christian faith may be incompatible with some career options in academic medicine. A few years ago, I was a finalist for the deanship of a major state medical school. And the chancellor of that university told me that as dean, I would be expected to go to the state legislature and defend that school's neuroscience research, which included the use of brain tissue from aborted babies. I told him that I could not do that, and that was the end of my candidacy. I suspect that support for embryonic stem cell research is a litmus test for most medical school deanships in the United States today. I can even foresee the possibility that authentic Orthodox Christianity may one day be incompatible with the practice of some medical specialties. In 2007, the American College of Obstetricians and Gynecologists published guidelines on the limits of conscientious refusal in reproductive medicine. The ACOG specifically said that conscientious refusals should be limited if they constitute an imposition of religious or moral beliefs on patients. The ACOG also said that physicians have a professional, ethical obligation to facilitate patient access to the full range of legal reproductive services, notwithstanding their moral or conscientious objections to those services. The ACOG definition of reproductive services includes abortion, and the ACOG completely ignored the issue of moral complicity. 2 years ago, this essay, published in New England Journal of Medicine, made light of physician rights of conscience. The author wrote, as the gatekeepers to medicine, physicians and other healthcare providers have an obligation to choose specialties that are not moral minefields for them. Do you have qualms about abortion, sterilization, and birth control? Then do not practice women's health, they wrote. Protecting the rights of physician conscience is one of the most important issues in healthcare today. As we move toward a government-prescribed healthcare system, individual rights of conscience may be swept away. This will be a difficult fight. It is a fight that, logically, we should win. But sadly, many physicians do not think that this is a battle worth fighting. In a recent survey of 1,000 United States primary care physicians, 57% agreed with the following statement: sometimes physicians have a professional ethical obligation to provide medical services even if they personally believe that it would be morally wrong to do so. Just 2 weeks ago, the Canadian philosophy professor Edward Tingley gave a helpful lecture on this subject at a conference sponsored by the Christian Medical and Dental Association. Tingley noted that pro-choice activists have encouraged the public to believe that the moral rights of conscience are wild new ideas invented by religious zealots. He predicted that we will lose this battle if we frame our support for conscience rights as a matter of religious freedom. Tingley called attention to our American society's historic respect for the rights of the conscientious objector, successfully defended by opponents of the Vietnam War. Tingley outlined the key components of the argument for conscience rights. Namely, conscience rights are accorded when a cogent claim can be sincerely made that a grave wrong will be done. Clearly, the intent of abortion is the death of the human life in the womb, and it seems obvious that the life in the womb is an innocent human being. Tingley concluded that when the standard arguments for rights of conscience are applied, the case for conscientious abstention from participation in abortion is fully made. Abstention from participation in abortion is only one of many situations in healthcare that beg for the protection of rights of conscience. Think about this. For the last century, evangelical Christians have argued for and against the involvement of Christians in professions such as government service, entertainment, the media, advertising. One generation ago, who would have thought that we would debate whether a faithful Christian can and should practice obstetrics and gynecology in the United States? I pray that we will continue to remain engaged, especially in the academic environment, where ideas and policies are shaped. These are difficult issues, and the environment is increasingly hostile. But our arguments are based on truth, and by God's grace, we can make a difference. But it may be costly. I pray that your experience at Wheaton College will prepare you to be a countercultural Christian. Pro-life statements can take many forms. This is the cover of the 4th edition of my textbook, published in 2009. The covers for the first 3 editions were somewhat generic, and when planning the 4th edition, I specifically asked the publisher to include a maternal fetal image on the cover. I thought this would be a relatively simple task, but it was not simple at all. The cover design process required almost a year, and it was almost as much of an ordeal as the writing and editing. In brief, the publisher first produced a graphic image of a nude pregnant woman. The image was so graphic that my wife Janet said, if I used that image, I would be unable to show the book to my mother or our children. Other images followed, and they were unacceptable for a variety of reasons. Finally, we agreed on the image that you see on this slide. I do not know what you think of its artistic merit, but I hope that you will agree that it is in good taste and that it is a strongly pro-life image. In the preface, I wrote that this image draws attention to the fact that the anesthesiologist and the obstetrician provide simultaneous care for 2 or more patients, the mother and her unborn child. I then wrote that as I look at that image, I am awestruck by the miraculous beauty of conception, pregnancy, and childbirth. I used the word awestruck with care because I once heard a former Wheaton College professor, Dr. Robert Culver, say that we should use the word awesome only to refer to God. And so we should be awestruck only by those characteristics that are unique to God, such as God's creation of human life. I concluded the preface by citing Micah 6:8. He has told you, O man, what is good, and what does the Lord require of you, but to do justice and to love kindness and to walk humbly with your God. I conclude by introducing you to my family. June kindly earlier gave a few details. All of my successes and none of my failures are a direct result of the sacrificial support of my wife, Janet, who is here tonight. You see our other 5 children, including Annie, who is here tonight, our 2 daughters-in-law, our grandson, Caleb, and we are expecting grand twins in June. As you can see, we have been richly blessed. In this lecture, I have tried to provide examples of opportunities to pursue excellence and live out my faith in a career in academic medicine, a career that, by God's grace, is unfinished. Thank you for giving me this opportunity to share with you tonight.